So what I'm going to do is I'm going to talk a little bit about the research I did for my PhD, a little bit about the research I'm doing for SMaRteN, and also some other things that I'm doing at the same time. But in the sort of best traditions, in a way, of anthropology, I'm going to start with a story. And you could call it like an ethnographic vignette, if you like, but it's basically just a story. So it occurred while I was doing field work, which I'm going to contextualize in a moment. But all you really need to know is I was interested in people receiving the secondary mental health care in the NHS. So some people were, perhaps being treated for bipolar disorder, schizophrenia, a whole host of things. And these are mainly people who are deemed to have quite serious problems. So it's some of the people might also have been street homeless, some of the people losing their jobs, living on benefits, and so on. And I was chatting one day with this guy, and he seemed like a really reflective, interesting kind of chap. So the kind of chap that anthropologists like to get to know, because we feel we can learn a lot from them, and who knows, maybe get some really useful quotes from them. And he said, oh, yeah, I got bipolar disorder. And I said, well, what is that then? And he said, yeah, well, what I've mainly got is brittleness of mood. And I said, oh, that's new to me. I've not heard this phrase before, brittleness of mood. So I said, what's that? And he said, well, I don't have these like big mood episodes, but all the time my mood is kind of different. It's unstable, it's bumpy, it's jerky, it's, and I thought this is quite interesting. And he had quite a rich range of metaphors. He spoke about it being like toffee and stuff like that. We love that kind of thing. Okay, because I really thought, oh, this guy's really kind of got to the, not to the bottom of, but he's got a kind of rich, nuanced understanding of what's going on in his life, which the psychiatrist calls bipolar disorder. So I went away writing loads of stuff down, had lots of chats with him about brittleness of mood. And if I was thinking of him as my brittleness of mood guy, and then I bumped into someone else who said, oh, no, I've got brittleness of mood. I said, have you got bipolar? He said, yeah. Started to talk. So what's brittleness of mood? And this guy said remarkably similar stuff to the first guy. Oh, well, I don't have major episodes. I've got this kind of sort of chronic instability. My mood bobbles around, stuff like that. Maybe, a little bit different. I don't want to say exactly the same, but kind of slightly disappointingly similar. So I began to think, what's this brittleness of mood? So I began to ask around more people, because I was going to drop-in centers and stuff. So lots of people around who I began to know, who I could ask, gentle questions to. And it turned out that there's something in common with the other people who told me that they have brittleness of mood. And that was they all see the same psychiatrist. They got the phrase, the brittleness of mood seemed to be a thing that about half the people that this psychiatrist saw suffered from, but nobody else suffered from. So if you didn't, at the time of writing, during the people I worked with, at the time that I was working with them, you could say, what are the risk factors for brittleness of mood? Well, frankly, the risk factors are very clear. It's seeing this particular psychiatrist. If you don't see that psychiatrist, you will not suffer from brittleness of mood. But if you do, it's probably 50-50. There's a really high chance of brittleness of mood. Now, you could be like really skeptical and say, oh, well, brittleness of mood now means nothing really. It's just, these people are just voicing stuff. But I don't think so. Particularly the first guy who really, it really did seem to capture something that wasn't reducible to other terms, that seemed to be kind of fine-grained, close to their lived experience. But at the same time, clearly, what I was picking up on was something that had been kind of co-produced, frankly, between patients and the people who look after them. Brittleness of mood doesn't exist wholly independently of the doctor. It also doesn't exist wholly independently of the patient. There's some kind of quite subtle sort of interplay between the two. And I thought, this is really quite interesting. And in a way, it was one of the times, it was like a penny dropping moment for we need to be attentive to fundamental categories, foundational categories like this. We don't really know what they mean. This an apparent outbreak of brittleness of mood really doesn't tell you about the patient so much as it tells you about staff, but it isn't wholly independent of what's going on with patients. There's some kind of mid-position there. So that, I hope, is the kind of spirit with which I do my kind of ethnographic research in mental health care. Now, the work I was doing at the time was for my PhD. So this is a few years back, between 5 and 10 years back. And I was doing an ethnographic investigation of a technology called True Colors. Now, True Colors at the time was a kind of web interface which emailed you or texted you, if you were signed up to it, prompting you to fill in validated questionnaires that purport to measure symptoms. So, I mean, I suspect there are people who know much more about this than me, but, things like, the GAD-7 or the QID-16 or Altman 5, or, there's these sorts of things. And over the course of my fieldwork, which was more than a year, it was added to, it was developed in certain ways, so people could start to ask their own kind of symptom, they could add their own questions and so on. But the key idea about it was that you own your own data. So it seemed to be a kind of response to something that I'd seen and was quite concerned about, which was, people become kind of passive, they become disempowered by being patients. Because the doctor knows everything, the doctor tells them what to do, they start to, kind of wait to be rescued, and that seems to be a bad thing. So I was excited by True Colours. I thought, well, this might be a way of reversing that. And I also thought this quantification of self might be interesting. To me, I could never fill in the questionnaires. I mean, when I looked at them and I tried to fill them in, it just made no sense to me. Like, I could fill in things, certain sorts of questions actually about, like, I don't know how many hours I'm sleeping, or has my weight changed. My weight always goes up and it never seems to go down. But there were other things that I really kind of didn't really make sense to me. Like I don't really, as far as I know, have a mood that could be scored. So I was kind of intrigued by this and interested in it. And my plan, of course, was to do the full anthropological immersion. So really getting to know patients, really getting to know staff as well, try to understand the world from their point of view, the pressures on them, the concerns that they have, their kind of values, their lived experience, and so on. And I kind of expected staff to be sort of share my excitement, really, to think that, well, we don't want to disempower our patients. We want to reduce stigma. We want to, get people sort of to have a kind of active role in the management of their own health. But actually, although research staff loved this thing, True Colours, clinical staff hated it. And I thought, why so? And they told me, well, the problem is, Neil, it doesn't fit in with the job. And I began to see, we had lots and lots of conversations, and people used to talk about the job. The job isn't like that, Neil. This isn't really what the job is. Like, researchers think that's what the job is, but it's not what the job is. So I began to see that the job became a kind of target of my research, if you like, because I began to see the job isn't necessarily what people want to do. It isn't necessarily what people's training suggests. It's something that they find that they have to do or feel they ought to do when they actually pitch up at work. So I began to see the job is a very complex thing. The job isn't, for example, I was very familiar with lots of critiques of psychiatry, people saying the DSM is terrible, all that kind of stuff is terrible. But actually, the job is quite different from that. The job isn't just, you can't deduce the job from the DSM. Just like you can't deduce the job from medical training, you can't deduce the job from textbooks guiding, people and so on, psychologists, for example. The other funny thing about the job was that it was secret. So quite often, and particularly as I began to win people's kind of trust, they would draw me to one side. And they would say, oh, well, Neil, the thing is, we say we do this, but really we do that. So we say we like to empower patients, but really it's a nightmare to have empowered patients. So we say we want patients to make their own kind of decisions, but actually it makes the job a lot harder to do. And in fact, I now say if I meet people, I've got some sort of friends who are doing field work at the moment in the NHS. One of the questions I was asking is, have you yet had your first conversation with a consultant psychiatrist who says he doesn't believe in RCTs? Because you will. And it just blew me away, because my entry to mental health care was through contact with kind of very high status research clinicians in Oxford who are kind of primarily trialists. I assumed all psychiatrists were into evidence-based medicine. They all kind of basically believed in this kind of evidence base, but they don't. They have a much more complicated relationship with it. And they're very happy when they trust you, when they know that you're not simply going to, report back to the head of department what they said. They'll tell you this. They'll tell you that. And I suppose one of the thoughts that I had was we can't have a research method that misses this stuff out. This is too important. If we have staff, for example, telling me I'm not sure I'm helping my patients anymore, or there's something about the job that means that I can't really do the things that I think really help. We have to be able to say that. It seemed to me to be really kind of really important. So, in other words, what I began to think was that if I wanted to answer the question, why does staff not like true colours? The answer was because of the institutional setting, basically, because of the way that the institution defines the work that they have to do. And I was aware, in fact, I have to say, I did have to kind of zoom off to the library a bit, because I realized there was quite a rich literature about bureaucracy and accountability, and which described the way that when work becomes bureaucratized, when it becomes put into a certain sort of setting, it becomes changed, it becomes shaped, reshaped, reformed. And what kind of the way that the job starts to be conceived becomes reshaped and reformed. And there's rich literature on this actually in higher education, in the military. It's kind of broadly based ethnographic fieldwork. But the shocking thing is that it's effectively being a good accountable bureaucrat starts to become how to be good at everything. So, for example, if you listen to psychiatrists say, what makes a good psychiatrist? Well, it's about being dispassionate, reasoned, relating instances to evidence, following guidelines, keeping good notes. It's all this kind of stuff. These are the qualities of a good bureaucrat, actually. And I think it's not necessarily a disaster that that's the case, but I think it's worth considering, is that what you want a psychiatrist to be? Because it's not how they used to be. I would sometimes, like, if I used to go to the pub with this guy who's just now retired, was on the brink of retirement, who said, like, all the art of psychiatry has been squashed out of it. We all just have to behave, in this kind of routinized way. That'd be my word, routinized way. So the question might just be, is this how we want mental health care to be? And can we at very least recognize that this is what it's like? There's also a second thought that why has it become this way? Well, it's become this way not because of research. It's not about kind of clinical need. It's not really emerging evidence. It's become this way because this is what, well, broadly, because this is what a good institution looks like to current sensibilities. It's a kind of, ethical and aesthetic thing, but it also enables market mechanisms to be created. So if you want to have in competition within the NHS, you need to have like a level playing field with defined ways of comparing competing service providers. And so you need these sorts of changes to take place. If you have clinicians who are, say, for example, basing their work on intuition and feeling and gut instinct and so on, or, some of them are a bit Freudian, some are a bit Kleinian, some of them are, you're not producing the kind of documentation required to enable competition. But the risk here is, of course, that the cart is kind of pulling the horse. Okay, so this leads, I think, quite nicely onto kind of SMaRteN, because what in a way, at least for me, what's exciting about SMaRteN is we have an apparent epidemic of poor student mental health, reports of poor mental health. I would say for my students, by the time people sit finals, about half report disability arising out of mental health problems. So it's a high number. But the question is, to what degree is this like the outbreak of brittleness of mood in Oxford, or to what degree is this, how do we sort of evaluate it? And I mean, my thought might be, there are ways to evaluate this. There are ways to evaluate. There are ways to contextualize and understand in a richer way what these sorts of changes mean, but it requires fieldwork. It shouldn't, I think, just be based on reflection or guesswork or anecdote. It requires kind of people to get into the field to understand the social life of categories and labels and metrics and quantities, and to see how they may be negotiated in individual lives. So I thought Nicola, with I think both kindness and insight, thought, let's introduce anthropology to SMaRteN. And what we're, I think, trying, at least what I hope we can do, is by co-producing ethnography with people with first and second hand experience of the frontier really between disorder and lack of disorder. So people who might say sometimes in certain settings regard themselves or describe themselves as suffering from mental health problems or having a mental disorder, but at other times might not. I might use alternative vocabularies or simply not regard this as a problem, we might understand something about what it means for someone to start to say that they have a mental health problem. Okay, so yeah, okay. So let me just close with a couple of reflections, and then I hope there'll be a sort of I'm imagining a kind of Niagara of questions, but I don't know because I can't hear anything at all that's going on. So I want to suggest that like the sort of skepticism that social scientists show towards fundamental categories that perhaps aren't questioned in the same way in let's just say psychology or psychiatry, it can lead to just people talking past each other. It can really lead to, you know, you get a whole bunch of social science and humanities people who work on, say, mental health, getting in a room. We all know best. We all know that these categories are kind of complex and they have a social history and they arise out of certain sorts of conditions and they're really about neoliberal self-management and the ethical project of the state and all that kind of stuff. But we're not saying anything of any value, really, in the sense that we're not saying stuff that clinicians or clinical researchers need to know. So, but I want to suggest it is possible to do that. It is possible to start to say, well, although I think it requires kind of effort on both sides, it's possible to say, well, maybe we need ethnography to show what the numbers mean. You know, maybe if we find an increase in people describing themselves as experiencing brittleness of mood, you might, if you have an ethnographer on the ground, you might be able to contextualize that and understand that in a way that's really valuable or important. But my second thing would be, and this is wholly different. What do you think, as people from other disciplines, who are mostly, I think, psychologists, what do you think people like me should do? What do you think would be the best way to produce ethnographically informed or anthropological knowledge that will be relevant to clinically oriented research? Thank you.